Hi guys, Dr. Gillard. I'm here with my grandson Chris again. You guys owe him a big thanks because I know he doesn't really want to be here, but he's being such a good sport. Thank you, Chris. Okay, let's try to go over this darn blood pressure, see if we can't figure out how to do this. Now, you can teach it. There's a couple ways to do it. You've been taught a one-step method. I'm going to show you a two-step method that is in accord with Bates, Jarvis, and Seidel, all the books that the board uses. So that's two-step procedure. Okay, first we're going to put on the cuff. So get the right cuff. So this is not a full adult, this is a small adult cuff because he's not a giant guy yet, although he sure is tall, but he's still a little skinny arms. So cuff is on. Okay, 2 fingers sliding under. A lot of you guys way in the CCEP exam, way too loose. And then where in the heck is the brachial artery? Okay, I see a lot of you guys, I know you're taught this, you got your fingers underneath the cuff trying to find it on the inside of the biceps. As we learned in CVP pathology with the Doppler ultrasound, all you got to do is go right here. Okay, it's medial to the bicep tendon in the cubital fossa.
Hi guys, Dr. Gillard again. Let's insert a little anatomy section in here since I'm work in the anatomy department and know this stuff pretty good. So went to Google Images and just pulled this out. It's unidentified, but thank you Google Images. But it's a very nice dissection of the cubital fossa. What's an AK for the cubital fossa? Antecubital fossa. So here's the lateral part of the elbow. This is the A to P view, anatomical position, medial view. So the cubital fossa is formed by 2 muscles. The walls are formed by this long muscle here. What's that muscle? That's the brachioradialis. And then the other side, the medial side of the triangle, is this muscle right here. That's pronator teres. If I would have panned out a little, you see the triangle, the tip, they meet down here. And then what's the base of the triangle is, well, you can see where the lateral epicondyle of the humerus would be about here, and this would be about the medial epicondyle. So if you draw an imaginary line between those 2 structures, that's the base of the triangle. So the contents of the cubital triangle, from lateral to medial, we have the radial nerve is coming down through here, right? And it branches into a deep, there's the superficial there. And importantly, this is the biceps. Now in the cadaver it's quite shrunken, but in most people it's much bigger than this. In fact, it would extend all the way over here, but it's pretty skinny in this specimen. So, and then the biceps tendon the biceps muscle becomes tendinous, and here you see the tendon of the biceps. And there's the biceps aponeurosis right there. Next structure heading medially this is the one we're interested in, carrot-like structure. This is the brachial artery. And the brachial artery splits, this usually down toward the tip more, but this one's actually splitting up higher. So there's the radial artery, and it splits into the ulnar artery right here. And then of course this is the what? The most medial structure. This is the important median nerve. Median nerve. So there's the anatomy, but you can plainly see what an easy place to palpate and auscultate the brachial artery. Right here, if this is the epicondyle, this is all medial condyle. So as I showed you in lab, if you can't find it, all you do is extend their elbow to the fullest, and it traps this artery against the medial epicondyle, and it's so easy to palpate. If you still can't find it, have them flex their bicep a little, feel the cord of the biceps tendon, and slip off medially, and most of the time you're going to be right on target. Sometimes you have to go a little farther medially because of the anatomy of just the difference of anatomy, but let's turn on some toys here. I was playing with Photoshop last night. So there's the brachial artery, that's your target. Again, there's the triangle, there's the cubital fossa. I don't know why they don't call it cubital triangle or antecubital fossa. And there, where does our stethoscope go? Medial, don't trust me, read the books. Medial at the base of the cubital fossa. Medial to the biceps tendon is the target of auscultation and palpation. Look at that. Look at that Photoshop skill. All right, so I think we got the picture. Let's go back to the video.
Okay, that's right here. All the books show that picture. That's the best spot to get it. If I try to go up here, remember we can find it with a Doppler, but it's in deep, so you have to dig in there to get the patient. And then how the heck do you put your bell way in there, or I guess we're using a diaphragm. In this case, we'll be using a diaphragm today. You can use your bell, but it's really difficult to get it in here. So why reinvent the wheel? Put it right here. Okay, so it would go right here. But we're not doing that. We don't need that. We're part one still. We're just finding the cutoff pressure. Okay, so to find the cutoff pressure, it's real simple. You can, let me see, I might have to modify this so you can see. I'm going to try to get his arm up here. Okay, that's working so far. You can still see. Can you see my regulator is right here, my little ball that I'm going to squeeze? Okay, I'm going to put that in my right hand. You see I got his arm pinched. Okay, I can see the dial. I don't know if you guys can see it or not, but we'll give it a shot. Now I'm going to find his brachial artery, which, oh, we're lucky he's got a really palpable. And you guys, when we're in collab, you find these things. Okay, I know a lot of times you don't really know where they are and you're just kind of faking your way through. Like the person who didn't put the earbuds in their ears and told me it was 140/80. So take your time in lab and practice finding the pressure or finding these pulses. Let's say I couldn't find it. To magnify it, I could extend his elbow more. Now it's really bounding. Okay, what did I do? I just trapped the brachial artery against the medial condyle of the humerus. Okay, it's so easy. If you got a big guy with meaty arms, push really hard and compress the artery down and then back off and you'll feel a big spurt of blood to help you find it. Okay, he's really easy to find. You guys should have him for a lab partner. Okay, so I'm going to close, I don't know if you can still see this, you can kind of see it here, but I've closed my valve off and I'm feeling that artery. And now we're going to start going up slowly. I'm going to find the point, the cutoff. I'm going to find where that cutoff point is. Now look at the needle. Can you see? I don't know if you can see it, but it's still bouncing. Okay, so it's bouncing at 80. Now if I go up to 90, it's gone. Even though it's still bouncing a little bit on the gauge. So it's still bouncing, but it's gone. It's cut off. That's because the whole cuff is registering it. It's not where my fingers are, so be careful of that trick. So his cutoff pressure, I was talking, I forgot. Let's do it again. Sorry, Chris. Check it just to make sure. Cutoff is definitely here. We're going to say it's 90 on him. Okay, cutoff is 90. I don't need to pump up anymore. I already got the number. There's no sense of pumping up any further. This is a two-step procedure. Let all the air out. The books say you have to let them rest for 30 seconds. And I think that's the way that the other instructors kind of just want you to do it in one step. But I don't like it. I'm kind of an old fuddy-duddy. I like to go with what's in the books, and this is how I want to see it. So, how you doing, Chris? How's the wife? How's the kids?
Very good.
Good, good. So, it's a good time to talk to the patient. You got 30 seconds. Okay, 30 seconds are over. Let's put the cuff back on. Okay, 2 fingers. Okay, nice and snug. Arteries pointing there. Should be about 2 fingers length above. What's the base of this triangle called? Cubital fossa, which it should be called the cubital triangle, right? Because it's a triangle. So here's the triangle. It's right at this crack of the arm here. That's actually called the cubital crease, or the anticubital crease is an AKA for cubital and anticubital are AKAs. So right at the base of the epicondyles, that's the base of the triangle. That's where you find the brachial artery. Here's his bicep tendon. It's just medial to the bicep tendon, not medial to the bicep muscle. Although you can find it there. Again, I don't recommend it there. Okay, so we're good. About 2 fingers up. That's about an inch or so. We got 2 fingers, we're good to go. Now I'm not obviously not going to put these in my ears right now because I want to talk to you. But now we place this at the base of the cubital fossa. Okay, now here's the tricky part. Let's get my gauge so I can see it. Now, they teach you not to hold your thumb over the bell, okay? But you can still hold the edge of the bell with the edge of your, like this. And this is because this is not a full adult cuff, so the base is a little wobbly. It would be nice to go like this, but it's kind of hard to do it like that because we have to raise his arm up. We have to get the arm up to the heart level. Okay, so just relax, Chris. Get my gauge over here. Okay, put on my stethoscope. All right, so there we go. I guess I can do it like this with him. I can still see the cuff. Hope you guys can see okay. All right, I'm closing my valve, and I know in my head that we're going to go 30 millimeters above 90. Why in the heck are we going 30 above 90 is cutoff pressure? Why? Oscillatory gap, right? We really should go 40 millimeters. There's new research says oscillatory gap can be even 40 millimeters, but we'll stick with the books, and the way you were taught was 20 to 30. So let's definitely go 30 millimeters above the oscillatory gap. I just slid my valve so I can see my valve a little bit better. And then I'm sliding the part of my belt underneath the cuff. If you have the cuff right, you should be, I don't know if you can see it or not, but the superior part of my belt is actually underneath the cuff. So I can go like this on the outside, like the peace sign again, or I can go down here. Let's go down here just to keep all the instructors happy. And here we go. So here we go. We're pumping up slow. Now I would be listening. Cutoff pressure here's 90. So we're going to go 30 above 90. So we're going to go up to 120. Okay. And now I'm going to let the... Now watch the speed of this if you can see it. Just by the gauge, it looks like he's about 110 over 60. What is the speed? It's 2 millimeters of mercury per heartbeat. So most of you are going too slow, way too slow. So I don't know, I'll try to zoom in the best I can to show you that speed, but that's something I went over a lot of, in lab I went over what the proper speed was. So what the heck is the oscillatory gap? I'm going to ask you that. Why do we go 30? What is the oscillatory gap?
Hi again, Dr. Gillard. Let's insert this into our blood pressure video here. Let's talk about Korotkoff sounds and blood pressure. What in the heck is blood pressure? Basically, the name of the game is this. You are going to clamp off the brachial artery with a cuff until no blood flows, and you're going to confirm this as with the procedure we talked about. Then you're going to slowly release the pressure from the blood pressure cuff until you hear the first squirt of blood, and you're auscultating over the brachial artery to listen. Can't hear this with your own ear. And that first squirt is the systolic part of the blood pressure. That's the first squirt. Then you're going to listen down. You're going to the cuff pressure is going to get lower and lower and lower, and finally you're not going to hear anything at all, nothing. And that is going to be your diastolic reading. Now there's a little controversy over that, but that's the way the research is going right now, and that is a check with the dean of the college, and that is the policy we are using here at Palmer. So that's it. That's blood pressure. But of course, being the scientists that we are, we have to make it more scientific and more descriptive than that. So Korotkoff came up with 5 phases and 5 different tones and pitches of these sounds as you go from systole to diastole. And the first appearance, this faint, clear tapping sound, that which is systole, that is called Korotkoff 1 or Korotkoff phase 1. And then as you listen, it will change into a muffle or swishing sound. That's going to be Korotkoff 2. And then it's going to get very loud as the blood flows freely through that opened artery. That's Korotkoff 3. Oh, I guess we can read them right here. And then Korotkoff 4 is another change where it becomes a very muffled sound. If you've listened to a lot of these, it does literally become muffled. They say blowing. I'm not sure I agree with that, but some people describe it. It's definitely like somebody put muffles on your microphone or on your stethoscope. And then finally, there's a period it grows very, very faint, and the last sound heard before a period of continuous silence, that is Korotkoff 5. Okay, it's not really a phase, it's just that last sound that you hear. And that is what we are using for diastole these days. Okay, so now let's talk about the oscillatory gap. For some reason, in people who have hypertension, sometimes a lot of them, here's a study we're going to look at in a second where 40% of the patients in this study, patients with hypertension, had a oscillatory gap. And here's the story. So you pump up, let's say you weren't really finding a cutoff pressure, which is common in practice, by the way. I mean, most people just go up to 180, 200, even though it's a hair uncomfortable for the patients, just to make darn sure they don't miss the oscillatory gap. And they come down, and at 160, they start hearing Korotkoff 1. Tap, 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 tap. And then all of a sudden, after maybe 10 millimeters of mercury pass, if you drop down to 140, all of a sudden there's silence. It's like, oh my God, that can't be diastole. So they're scratching their heads and they're keeping going down, and all of a sudden it comes back. Now it comes back at 130. So that weird silence in Korotkoff 2 is the oscillatory gap, and that's what you have to be careful of. Maybe I forget what we're using. I think we used, what did we use, 150 or 160 was the Korotkoff 1. Then at 150 it disappeared. That might go down, that silence might go down 40 millimeters, right? It might go down to 50 to 40 to 30 to 20, and then all of a sudden it pops back up. And so you'll say, oh my God, his diastole is 120, when it's not. You keep going and it goes. So that gap is what can cause trouble. So if this patient's blood pressure is 160 and his oscillatory gap is at between 150 and 120, and we pump up to 130 or 140, what are we going to hear when we start auscultate or start listening? It's going to be silence, right? Because we're in the oscillatory gap. And then we're listening at 120 or so. Now we hear Korotkoff 3, but we don't know that. We think it's Korotkoff 1, right? Because we started in the wrong place. And that's the whole point about finding the cutoff pressure, just to make sure that you go 30 above. And I would, in real practice, I like to go 40 or even 50 above, just to leave no doubt that there's not an oscillatory gap. Okay, so I hope that makes sense to you. Now let's drop. Oh, what's another reason I like to go a little higher than normal? Because when you start taking the blood pressure, you start getting situated, sometimes the cuffs leak a little bit. If you go 30 above, by the time you're done fooling around with your stethoscope, especially if you use that one-step procedure, right? You got to switch gears, put in your stethoscope. A little air might have leaked out, and now you're only 20 or 10 millimeters above, 10 millimeters above the cutoff pressure. So anyway, I digress. All right, let's finish this up by looking at the Cavallini study. It was published back in the late 90s in a very respected journal. There hasn't been a heck of a lot of more research done on this, but it's quite interesting. So what did the Cavallini study do? It looked at 168 patients that had hypertension and were not on medications. They were all ultrasounded. Their hearts and carotid arteries were ultrasounded, looking for some of the danger signs of stroke and coronary artery disease and heart attacks. Some of the danger signs, of course, are what? They're looking for stiffness of the arteries and left ventricle and plaquing. So they wanted to see if this oscillatory gap would be predictive of some of these danger signs, and in fact it was. What were the results? 21% of the patients had an oscillatory gap. So that's quite a bit higher than the numbers our board books use. Although this was a small study, that's an eye-opener there. So stiffness of the arteries, not the left ventricle, but stiffness of the arteries was definitely seen more frequently in people with an oscillatory gap. The p-value was 0.005. Atherosclerotic plaquing was also seen in patients with the gap. In fact, it was over twofold, approaching a threefold increase. So having an oscillatory gap is pretty predictive of atherosclerotic plaquing, which is a danger for stroke and heart attack. P-value on that one was 0.002. So interestingly though, between the non-gap patients and the gap patients, their blood pressure levels were the same. The left ventricle function and hardness was the same. Cholesterol levels were the same, and smoking history was the same. So it's interesting, this gap is predictive. We're not exactly sure why that is, but it definitely seems to be predictive. So if you have a patient, if you even find an oscillatory gap, you better get him out or her out to a cardiologist for a good workup. Logistic regression analysis indicated a few independent associations with the gap. One was being female, one was arterial stiffness, one was atherosclerotic plaquing. So bottom line, if you even find a gap on someone, then that patient should be referred to a cardiologist for further workup. Okay, good luck on your test, and we'll see you in the next video.